Hi, I'm Colleen Hutchinson. I am here with Ajita Prabhu at the 19th Annual Minimally Invasive Surgery Symposium at the Wynn Encore Las Vegas. Ajita, thanks for being here.
Thanks so much for having me.
Can you just tell us a little bit about yourself, please, first?
Sure. My name is Ajita Prabhu. I'm an associate professor of surgery at the Cleveland Clinic. I've been in practice for about 9 years now, and I did my training at Maine Medical Center in Portland, Maine, and then I did my fellowship training in GI and minimally invasive surgery at Carolinas Medical Center.
Let's start with the robot. Would you say the robot is more advantageous to use in laparoscopy in certain procedures?
I would say the jury is still out on that. I think for sure there are a demographic of surgeons who are not comfortable with laparoscopy, and they are adopting the robot for applications such as robotic inguinal hernia repair. And I think that's one thing. It's a little bit different than what you're asking me, which is, are there advantages over laparoscopy in robotics? Specifically when it pertains to hernia repair, there's very little comparative literature out there right now at the moment that's prospective or well-designed to answer this question. I think the things we are going to need to look at are operative times, for sure, cost, for sure, and then the main question that remains to be answered is there a clinical benefit to using the robot for hernia repair over laparoscopy? And I would say right now, it's still too early to know.
Okay. So you use the robot sometimes, though. How do you decide when to use it versus not?
My robotic practice is evolving, and I should say, for clarity's sake, that I am participating in 2 prospective randomized controlled trials.
Okay.
And so what that means is the majority of my robotic cases for right now are being randomized to either robotic or laparoscopic inguinal hernia repair or robotic or laparoscopic ventral hernia repair. So I would say that's one caveat to my robotic practice. In other areas, I'm exploring robotic abdominal wall reconstruction. And the reason that I'm looking at that is that I think it's an interesting way to accomplish a very similar operation to an open abdominal wall reconstruction through small incisions. The question remains, is there any advantage to it? But in the meantime, while I'm deciding what to use the robot for, what I would say is I am picking straightforward cases, particularly for the abdominal wall reconstruction, central defects that aren't too big, not too complex, things that are easily achievable, but that I would still do an open abdominal wall reconstruction on.
Okay, thanks. So there is conflict, though, surrounding the robot, and most recently, I think we talked about this in an On the Spot recently in General Surgery News, the American Journal of Surgery article that came out that really spotlights this link between the current robotic literature and conflicts of interest on those by those authors. It sort of demonstrated the need for concern in this area. What would you say about that concern?
So what I would say isn't necessarily concern, but I would probably use the word awareness. So
Okay.
I think that anytime that there's a new technology, this is how it evolves. So the surgeons that have the greatest experience using the technology are naturally going to be the surgeons who write about it, and they're going to be the surgeons who speak about it. And perhaps in that case, they have a greater body of experience to speak to whatever that technology is, right? So then what that means is their industry provider is going to pay them to speak on their experience. So this is almost the natural evolution of things. I think the important thing is that for surgeons who are interpreting the literature or the talks that are coming out of this, I think it's very important for them to be savvy about it. I think it's important for them to go in and understand any conflict of interest that exists already so that they can interpret the literature with that context. And also, very importantly, I think if surgeons are going to do both, in other words, write about it, and create the body of literature about it, and they're also going to receive payments from the company, I think it's important that they are forthcoming with that information.
In that On the Spot that we just did, Igor Belyansky mentioned, with regard to this specific question, that he doesn't feel that this is unique to robotics, although a lot of people are talking about conflict of interest now with regard to robotics. He made the point that this is really across the board, and talking about that natural evolution that you spoke about here. Do you agree with that?
I would say I agree with that. I mean, in robotics, it's fairly inevitable that this would happen because robotics, there is a monopoly right now in that market. But I would say that this phenomenon is not specific to robotics. It probably happens with every technology as it comes out, and then as the technology diversifies, so do the conflicts of interest.
Next, I want to talk about Botox. I know right now there are no head-to-head comparisons on in terms of using it versus not using it, but one, I wanted to get your thoughts on what its appropriate role is right now based on what we know, and also should it be used routinely in abdominal wall reconstruction?
I think that is a challenging question. I think like all new technologies, Botox has recently been introduced into the field of abdominal wall surgery. I would say at this point, without comparative literature, there's not a role for it in my practice. That said, there is a growing body of surgeons out there that have good experiences with it. They believe in it. So what I would like to see then is truly a comparative work to say, hey, this really adds something to the care of the patient, because without that, it's an expense and it's for unclear benefit. So I'm not saying no, but I would say my jury is out right now.
Okay. Moving on to meshes. Regarding the safety and vetting of meshes, there are different roles here. The FDA, you have the surgeon, you have the health systems, the insurance companies, and you have industry. And then you have the patient coming in and asking about it prior to surgery. So who would you say is responsible for the safety and vetting of these meshes that are coming to market, before they come to market?
Okay, before they come to market, I would say that is a real challenging question. I would say primarily the FDA is responsible for making sure of the safety of the meshes. However, that is in conjunction with the industry that's bringing the mesh to market, because industry for sure stands to gain a lot from bringing a new device to the market. So before the mesh actually hits the market, as it's going through its 510K clearance process, I think it is important not only for the FDA to be likely more stringent than we have our system right now. But I also think it's important for industry stakeholders to a little bit put their money where their mouth is. If you're going to introduce a new device and that's going to be put into patients and it may be there forever, I do think that the onus is on them to then provide some literature to support the safety of the device.
Yeah. So after this mesh comes to market, how would you characterize the role of the surgeon in talking to your patient about mesh?
So I think the role of the surgeon is a key one. And I should say, to add on to the last comment that we just said, it's saying a lot to make the assumption that the FDA and industry providers are responsible for the safety of the mesh. Our current system has been widely outstripped by technology. So the FDA has not, up until this point, been prepared to handle that kind of onus or that kind of burden just based on innovation and technology. So when I say that, I recognize it's a little bit more complicated than that, but hopefully that's where the ball will stop. As far as surgeons go, when they're talking to patients, I think they play a very key role in the discussion of the device. I think it's important for surgeons to understand what device they're using and why they're using it, and then also some of the pitfalls as well as the benefits associated with that device. I'm not saying that every single office conversation has to revolve around that, but I think there should be enough of a conversation between the patient and the surgeon has to be educated enough to be able to have that discussion every time.
They should definitely know quite a bit about the devices and the materials, and also keep up on current literature.
I think so, and I think also importantly, if the surgeon has any conflicts directly related to the device that they're putting in, I do think that should be made transparent for patients.
Okay. So you have been involved in some new research regarding a couple of different variables that were considered historically to be contraindications to surgery for symptomatic hernias. Smoking, BMI, epidurals. What are your thoughts on that, and how would you say, what is the data telling us now?
So this is an interesting discussion because the Quality Collaborative, as you know, has been a labor of love, and we are just now getting to the point where we're starting to be able to pull some good data out of it. And I think with many things in surgery, we're starting to see that maybe we don't really understand things on the level that we thought we did. So have I made any broad changes? Not necessarily. The smoking literature actually that we have recently published really reiterates other literature that's already been put out there. There's a large NISQIP study that says essentially the exact same thing. I think the difference in our paper versus that paper is the interpretation and the conclusion that's drawn. So I'm not sure that we're finding actually huge differences in the literature, at least with regards to smoking. I think what we are saying is, well, hold on a second, we spent so long saying that smoking is a terrible thing and we shouldn't operate on patients who are smoking, but perhaps there are patients in need of an operation who won't do as bad as we think they would while they're still smoking. We would still absolutely discourage it. I don't think smoking is good for your health. And we know that there definitely is an implication in CDC class 2 and 3 cases for smokers. But I would say with clean cases, perhaps this allows us to expand our practice just a little bit to allow for operations that may need to happen. When it comes to BMI, so the obesity argument, I mean, we've always said it's better to lose weight. There's no cutoff point, and that's really the news to us.
Right.
We don't know the exact BMI at which we can safely go to surgery. I think we continue to give the same message, which is the more weight that we can lose for obese patients, the better they'll do with surgery. So I think that message hasn't necessarily changed. When it comes to epidurals, I think that our new findings have given us pause. We've discovered that by virtue of having an epidural, the patients are staying in the hospital at least one extra day. What does that mean when it comes down to the brass tacks? We don't know exactly. So we don't know for sure if it's that the epidurals are not functioning well. We don't know if it's a function of having several different teams involved in the patient care. I don't think we were able to get granular enough to make that kind of distinction, but what we could say is that in a fairly large group of patients that were well-matched, epidurals versus no epidurals, the epidural patients without argument stayed longer. So I think for that study, that gives us pause, and it just makes us think, okay, it might be time to go back and look at what has previously been just an accepted intervention. And I might add, epidurals are an intervention. We're doing something to the patient. There is the potential for harm. And this has been a foregone conclusion all of this time, that epidurals were the thing to do when we were having major abdominal surgery. So I think this gives us a little bit of room to say, the onus is on the intervention to prove itself to be effective. So I think there's more work to do there.
Well, so with regard to epidurals, what would you say now, and what are you doing in your practice following that research with regard to epidurals versus tap blocks?
Well, initially we switched to tap blocks all the time using Exparel, but then we also discovered that, you know, as we expected, we didn't see necessarily a great savings with length of stay with tap blocks.
Okay.
So the thing that we decided to do is what I think any good surgeon should do if they are setting out to ask a question, which is study it.
Yeah.
So we are setting out to do a trial now on exactly that. It's a prospective randomized controlled study evaluating the effects of Exparel versus Marcaine versus placebo in patients, and we'll see what the results of that are.
Great. Last question. Is there a role for biologic or biosynthetic meshes in AWR?
So, surprisingly, although biologic meshes and biosynthetic meshes have been around, biologic meshes for 20 years or so now, and biosynthetic meshes a little bit less time than that, but still a good 15 years. We don't have the answer yet.
Yeah.
So what I would say is in the past it's been widely accepted that synthetic mesh is undesirable in CDC class 2 and 3 cases. I would also say that the literature that that's based off of is not high level evidence. And so we've kind of had this effect of synthetic mesh is bad, don't use it in CDC class 2 and 3 cases. And so then came the uprise of biologic meshes and biosynthetic meshes as an answer to a problem that we're not sure exists. So at this moment in time, there's one prospective trial looking at biologic meshes in CDC class 2 and 3 cases without a comparison arm. And there's one prospective trial looking at biosynthetic meshes in the same wound classes, again, without a control or comparison arm. Okay. So what that means to me is, despite the fact that these materials have been around for a long time, there aren't good comparative studies quite yet, and I think we still don't know their role.
Okay. Well, thank you for being here today and discussing all of these topics.
Thanks for having me.